than here.
Yes, it was a good, well-organized event, I thought.
Yes, very, very well.
So we're waiting for the signal from the back team before we start.
Okay, we can start. We are live on YouTube also.
Okay. Thank you, Nico, for setting this up. So good afternoon to everybody. Welcome to another edition of the ENS webinars. Today is the turn of the spine section. Florian Ringel, the chair of the spine section, asked us to fill in his place. And it's a real pleasure. I have with me Professor Christopher Eans, who is a spinal neurosurgeon at University of California at San Francisco, internationally recognized for a wide spectrum of spinal disorders, including spinal tumors, deformities, including scoliosis and cervical kyphosis. Chris directs the program for spinal tumors and deformities at UCSF and co-directs the UCSF Spine Center. Does a lot of work, research in high-risk spine surgery, and today is going to talk to us about the machine learning and big data in adult spinal deformity. So Marcel and I will try and keep an eye on the questions, but to start with, Chris, welcome. Thank you for joining us, and look forward to hearing from you.
Well, thank you. Thanks very much, Andreas and Marcel, for hosting me. It's a real pleasure to be with you guys today and talk about our journey from basic data to predictive modeling and biomarkers, and it'll really be the story of where we've come from and where we're going. I have one significant conflict, which is I do a lot of work with Medtronic on their data systems and their enabling technology, but I don't think it's really directly related. First, when we look at a needs assessment, the first part of the talk is going to be why we need to do this. And one of the big issues around the world, not just the United States, is that we have an aging population. We have a high prevalence of curvature of the spine in the aging population. And what we've seen then in response to that is a higher number of adult deformity surgeries being done. If you look at it from an industry perspective, the AIS market is relatively flat. There's a lot of adult deformity surgery going on, both driven by the aging population as well as by a lot of short segment fusion being done that needs to be revised. So the market is really expanding. Furthermore, we have a tremendous competition for healthcare spending, right up against musculoskeletal disease and arthroplasty is dementia care. In the United States, it's estimated that dementia care will approach $1 trillion a year in the next 10 to 20 years. When you think about inpatient care, all the comorbidities associated with dementia, this is going to be a big drain on the healthcare system. And also we have then, therefore, high expense cardiovascular care. These patients are also having cardiac issues as they get older. And of course, other musculoskeletal issues besides the spine. So we recognized that we needed innovation. And our group published a review of what we call a failure review of all the failure rates from a large meta-analysis of the literature. And the failure was mechanical failure, clinical failure, reoperation, and cost ineffective failure. And we published this in Spine last year as a part of a process improvement, essentially just defining the rates. One of the things we found was that we were operating on increasingly older patients. If you look at the International Spine Study Group demographic, we see that the mean age of our population was increasing over the last decade. Their comorbidity scores were increasing. We saw some overall decrease in operative complications that occurred early in the decade, but the implant complications implant complications and neurological complications had started to increase a bit, actually, over the last 5 years. And as I mentioned before, we saw a decrease maybe 10 years ago, but more recently, the curve's been flat. We haven't been moving the needle more recently in improving the quality of care of these patients and the safety of their care. Additionally, and maybe even more concerning, was the approximately 20% reoperation rate in this population. This is across the United States, so this is not just one outlier. And looking at a whole lot of different studies, the average rate's about 20%. And why is this really concerning? It's particularly concerning when you compare it to other complex disorders, where you see it's up there with about double the rate of a AAA aneurysm repair. It's right up there with the survival of a microvascular free flap, worse than pediatric cardiac surgery, and certainly a lot worse than arthroplasty. I know this is a neurosurgical meeting, but our arthroplasty colleagues in orthopedics who operate on a lot of older frail patients are doing a lot better job in keeping them back out of the operating room. So this is starting to become a big problem. And then if you bring cost effectiveness into it, we see that adult spinal deformity surgery, this is obviously a US, US dollars, but if you bring cost effectiveness into it, it only starts to become marginally cost effective, modeled out to 10 years without a reoperation. So the typical incremental cost effectiveness ratio that's used by mature economies is around $75,000, maybe on the upper end, to say whether a pharmacologic intervention or an operative intervention is cost effective. And we're only reaching that at 10-year follow-up. So that becomes a big problem, and failure destroys this. So how have we approached this? Well, in my institution, we've approached it by spending more money at the index procedures. So this is one of our typical cases. You can see all the hardware in place. And these are our strategies, all expensive. Double pelvis, double rods, VCR rod, biologics, ligament augmentation, it's not reimbursed. Vertebroplasty is not reimbursed. 2 surgeons not paid for very well, and then plastic surgery. So our solution has been to spend more money at the index procedure, much of this not reimbursed. So this is where we are, and I think probably where we still are, although we started to identify some possible solutions that I think are mostly going to fall in data. If we think about, can we move this needle with implant innovation, making better screws? Probably that's not going to happen. If you look back over the last 10 years since the first multi-axial screw was developed, we really don't see much shift in the quality and safety of care through the next generation of any implant system, whether it's Medtronic, DePuy, Stryker, whatever. We're not going to move the needle with the next generation. It might just be an easier reducer or something like that, but that's not where the solution is going to lie. The solutions most likely, as I'll show you, are going to lie in data, but there are a lot of challenges to this, not the least of which is the fact that industry, which sponsors a lot of the work that we do as education, meetings, they are going to have a hard time shifting from an implant-driven monetization strategy to a software as a service strategy. And this is where they are right now. This is a very difficult time for them to figure out. They know this, but it's hard for them to shift from selling something and making money on something you put in a patient to making money from a predictive model, for example, and even precision implants that incorporate machine learning. So this is a struggle that we're going through together with industry right now. So the solution is probably going to be integrating data into a process optimization strategy. If you think of us as making spines as a factory, the first thing you would do would be quantify the rate of failure of whatever you're making, whatever widget you're making. And then you would start to implement process improvement strategies that would improve your ability to make widgets without error that were all successful. And this is the same thing we need to do in spine surgery. And probably, I'm going to show you and try to convince you of the fact that this process optimization is probably best going to be through data. It's going to give us better quality benchmarking rates. It's going to eliminate, to a large extent, human bias and human error, especially on judging who's a good operative candidate. In the future, it may start to eliminate structural and engineering related error. And in the last part of the talk, and where my research is mostly now, is in trying to quantify this unmeasured biological variation, and then trying to put all this together in what's called in a DMAC manufacturing optimization, a control loop process. This controls the quality of the product that we're putting out. So let's take them in order. The first, the lowest hanging fruit is on quality benchmarking. A great thing to quality benchmark is proximal junctional failure. And the way we used to quality benchmark this in the large registries, and I work in the International Spine Study Group, but I work very closely with the European group. We used to just draw an average value across the sites, and we would say, if you're over this average value, you're an outlier in terms of your rate of revision surgery for kyphosis, for example. And if you're under this average value, you're a good performer. And probably this is done in your hospitals too, on length of stay, and it's on average valuation without much good data to stratify the patients. And so we started to use predictive modeling to do this, where we actually quantify the patient's bone mineral density, we quantify the patient's frailty and other aspects of their comorbidity, their age, the magnitude of procedure they were having. And what we saw was a tremendous shift in the landscape of who was an over or under performer. The only way to really accurately quality benchmark is by developing the most accurate models that would say, at your hospital, in your practice, the types of surgery you're doing, the types of patients you're treating, this would be your predicted rate of revision for proximal junctional failure. An average value completely creates an inaccurate picture for quality. They can see sites that were under the average. Actually, many of them were underperformers, and many of the sites that had higher than average rates were actually doing a pretty good job. And this is probably one of the most impactful things as a society, as a healthcare system, where predictive modeling will show a good impact. The problem is, we can talk more about this in the discussion, very few hospitals or insurance companies or national health systems have enough of good quality data to build really accurate models. So that's one of the hurdles. Another area where I think we're going to see machine learning helpful to us in our practices is in trying to bring younger surgeons up to the level of the more senior surgeon earlier in their career. I know, when I trained, there was a much greater tolerance for error and higher complication rates with younger surgeons, and we just felt, okay, they mature over time, and they definitely did. But nowadays, at least in the United States, there's much less tolerance for that learning curve going on. And we expect, just like when you get in a plane, the younger surgeon or the younger pilot to have the same complication rate flying you as a senior pilot. And a lot of that's been through in aviation and been through enabling technology. So one of the ways we can do this is to try to inform the younger surgeon on who is likely to do well. We all know that most of our outcomes are based on really good patient selection. And right now, this graph actually depicts the outcomes of every patient in the North American and European registry in adult spinal deformity. And you can see they're all over the place. So if we could give a younger surgeon an accurate way to group patients according to their likely outcome based on data acquired through a decade of senior surgeons operating, this would probably be helpful for them in optimizing their outcomes very early in their career. It seems to make some logical sense. We learned a lot of this idea from cancer therapy, where they cluster patients now by genetics, by receptor type, by stage, by age and frailty, and they come up with much better treatment responses. So, and you can think of it as ASD, surgery is a treatment, and we want to not broadly apply it. We want to apply it to the patients that are most likely to benefit from it. So we developed, utilizing unsupervised learning, a way to cluster patients. So on the left, you can see like this is a typical good quality surgeon. He's looking at all, or she is looking at all the different variables. And on the right side is our database represented graphically utilizing clustering. What does clustering do? It allows you to say, okay, this is you, this is your patient in front of you as a young surgeon. These are the 10 most similar patients around you. And then this is how they were treated around the world by some of the world's best surgeons. And this clustering is based on not, 5 variables that the human mind can process maybe at the same time, but this is based on 75 or 100 variables, depending upon which system we utilize. So we think bringing something like this to the point of care, utilizing machine learning, is going to benefit the younger surgeon, because what does this do? Rather than a classification system for adult spinal deformity that's based on the sagittal plane, this bases a clustering-based classification on risk versus benefit in real time. So if you go to your patient cluster, and you match them to your surgical cluster, you can look just across the line and you get the major complication rate and you get the likely improvement in their disability scores. So this has been used in cancer and now is available in adult spinal deformity. And then you can even do fingerprint matching. This is something that industry is working on, to take an X-ray, overlay it in 20,000 patients in the database, and actually develop patients that are matched exactly based on their X-ray data. And this will allow you to easily pick out patients you operated on before and say, this is what I did before. This didn't work very well, or this worked very well for this patient. This is something I want to do as well. And you can also look at other surgeons across Europe, Asia, South America, and North America this way. Well, what about the most experienced surgeon? So you take somebody like, for example, a Dr. Lenke, or you take a top fighter pilot. How can AI make that surgeon better? It's probably not going to make them more accurate in terms of putting screws in, or how to do corrections, or even the judgment on who to operate on, because they're so seasoned, they have so much experience. But probably what we can do is help that experienced surgeon eliminate their noise and bias. So some very good books on bias. This is one called Noise by Daniel Kahneman, a very famous economist. Another great book on decision-making and human bias is a book called Thinking in Bets by Annie Duke. It's about playing poker. Selecting a patient for surgery is much more like poker than it is chess, because in chess, predictive models can be 99.5% accurate or more in winning the game of chess. Poker involves some element of chance, and there's always some element of chance in surgery. And one of my favorite errors that she talks about is the error of resulting in poker. This error is if you receive a hand and you make, it looks like a good hand to you, and you make a bet and you lose, you may have actually made the best decision you could make. You made the right decision. You just lost due to chance. And we, as surgeons, we do something similar. Many times we'll operate on the right patient, we'll do the right surgery, and something will still go wrong. They won't do well. And as humans, what we tend to do is we adjust what we do. We think, oh, I did the wrong thing in that patient. But you may have done exactly the right thing for that patient. Just by chance, something bad happened because of their comorbidities or something like this. They had a bad MI or a PE or something like this that was just bad luck. And we don't want to rethink our logical processing pathway on what to do, because we're emotional about that as a surgeon. So there's good data to support this. We've done some studies in the ISSG, ESSG registry, where we show tremendous variation in surgical judgment across surgeons. For example, if you look at major complication at 2 years, we asked surgeons to predict what they thought that would be based on case studies that we sent around to them. if you look at case 7, the human predicted the average risk was somewhere between 1 to 100%. So as humans, we have tremendous bias that differs by individual surgeon, which makes sense based on our individualized experience. But if we're really trying to be accurate in supplying that patient or that young surgeon or even the senior surgeon with the real risk of that surgery, our human bias and noise are going to be all over the place. It's not a good way to go about doing that. We then measured the correlation between the machine prediction and the human prediction and saw not very good alignment there. And then when we look at the machine's ability to predict complication, the machines were really right on. So this is probably the most impactful thing we're going to be able to do for the senior surgeon, is to eliminate this wide variation in their noise and bias. So we built multivariable predictive models, which we published now 4 years ago, on major complication, which was individualized for the patient. And we built predictive models for outcome across every common outcome instrument. So we can predict with 60 to 80% accuracy, depending on the instrument. We can predict the ODI post-op, the MCID for ODI, the SRS-22, and SF-36, all with about 60 to 80% accuracy, depending upon which domain you look at, rather than giving a patient an average outcome from a paper that's published. We can give them an individualized prediction of their individual outcome based on even the surgeon and the site and their frailty and their targeted procedure. So this is how it works. We start off with clustering. That gives us a general classification. It allows us to pull out similar patients from the database. We enter demographic information, radiographic and comorbidity information. And these are just data points that may change over time. And then this is their baseline data. And then we get in real time, after about 5 minutes, an estimation of their complication rate, reoperation rate, readmission rate from 0.0 out to 2 years. The first day can be interesting in terms of predicting who should go to the ICU versus the floor. And the 2 years are really important for humans, because humans were built for short-term risk to stay alive in the jungle under threat. We were really not built to predict 1 and 2 year risk. We're really bad at predicting risk farther out, and that's where the machines are much better. And then likelihood of clinical improvement, because you can't make a surgical decision only on risk. You need to integrate the outcome into that as well. To revisit the cost effectiveness ideas, when we simulated using the predictive models for cost effectiveness and QALY, which is the measure of quality adjusted life years, very commonly used in economics, we saw that the patients that were operated on according to the machine prediction had a 684% greater improvement in QALY than patients that the surgeon decided were good surgical candidates. So to me, this is maybe the most impactful slide from a health economy standpoint, that the machines do a better job of potentially spending our healthcare dollars than we do as surgeons. This allows you then at the population level. So if you're, in UK, Scotland, Germany, US, Spain, you can decide how much money you have to spend on the adult spinal deformity patient. And you can essentially draw a filter. You can say, we're going to tolerate this level of readmission or this level of complication. We're going to expect this level of clinical improvement because we have this amount of money to spend. And you can select patients on the front end that are likely to reach those filter values. If we do this in the United States, we draw a 50-50 filter, which we just made up. We decrease the rate of surgery by about 41%. And that reduces spending on patients that don't do well by about $500 million US. And this is in direct cost. In the United States, the billing to insurance is marked up about 3 to 5 times this. So it starts to become real money in the billions of dollars in terms of billing in the healthcare system. So that's where we were as of about 3 years ago. And so Ferran Police, who runs the European Spine Study Group, and I, who run the predictive modeling for North America, we got together and we were trying to figure out, where do we go in the future? And we were downloading additional data, 1,000 patients approximately per year from both groups. And we found that as we added more patients with the same data points, the models were not getting more accurate. So we thought initially that our accuracy was due to low numbers. We had a few thousand patients. We thought if we got 5,000, 10,000 patients, then we were going to see a significant improvement in the accuracy of the model. And we didn't see that. So what we started to think was probably, or one explanation, in addition to just random chance, one explanation is that we were missing the appropriate data. And so essentially the next 10 minutes of the talk and the last part of the talk is the new data hunt. What are we doing now for data? So we don't think it's another frailty score or another classification that's based on an R-squared value or something like this. This is not the right way to go, even though we still see it on the podium sometimes. We had a good general frailty score. It's called Edmonton. When we applied Edmonton to our adult deformity population, we saw that it was only 4% overlap in our population. It didn't work very well. We developed a frailty score years ago. This is probably 8 or 9 years ago now, that was disease specific. It was related to complication. It was integrated into our health system now, like we can actually use our ASDFI, the Adult Spinal Deformity Frailty Index, and it's built into our APEX systems now. We enter the data and we get this spit out in real time. It has been linked to procedure type, so it does help you to choose what operation to do, for example. This was a study that one of my minimally invasive colleagues did, where he looked at ASDFI versus open versus MIS TLIF, and he found that the frail patients had a much higher revision rate with open surgery compared to MIS surgery. So frailty has paid some dividends for us, but probably in the future, we can't still just be collecting the same variables for frailty and think that's going to improve our predictive models. We think that the only way to move forward, even though it's difficult, is taking all the variables at once. And I'll just mention, politically, there's pushback against this. Why? Well, the SRS thinks it's the Scoliosis Research Society thinks it's unapproachable. Like for the average surgeon, they want a frailty value, they want a classification, and all this predictive modeling with 100 variable systems is too difficult for the average surgeon. So I try to make the case when I give these talks that even though it's difficult, this is the way forward. It's not an easy path. One of the things that frailty showed us was it wasn't just predictive of major complication. It seemed to have impact across things that you might not have thought would be related to frailty, things like wound infection and pseudoarthrosis and PJK maybe. And this was starting to give us an idea that maybe frailty was reflective of more of a physiologic phenotype rather than just a scoring system, so to speak. So we took a step back as the European group and the International Spine Study Group, and we started to think, what else should we add to make our models more accurate? So I'll just take you through that. We added physical metric variables. So in my institution now, we do in-body 970 sarcopenic measurements. These are measurements of body composition. We do grip strength and time to get up and go. One of the things this represents why we think we were missing so much of this, if you look at SRS activity, which is a subjectively reported score, you can see that within the same SRS activity score, there's tremendous variation in the objective 4-meter walk. So if we only entered into our model the SRS activity score, we were missing a lot of the variability in those patients. We weren't accurately characterizing them, just using the subjective report. Also, grip strength is a very objective score for sarcopenia, and it's associated with age. And we thought grip strength was something that would be helpful to add. And here's an interesting data point that we just got this year. In thoracolumbar deformity patients, more than half of them had improvement in their grip strength after surgery. So think about that for a minute. We didn't operate on their neck, nothing to do with their upper extremity. Post-op, their grip actually got stronger. So surgery was improving their sarcopenia, and sarcopenic improvement measured by grip strength was related to their chances of reaching MCID. So the patients that had an improvement in their grip strength did better in their thoracolumbar disability. So it's all kind of linked together.
1, 2, 3, go.
On this same subject, we found that walking speed was also related to things that were expected, things like age. But if you look at the interconnectivity of it, which is kind of interesting, the most related variable to walking speed was not leg weakness. It was actually a cognitive score. So our patients that were more demented were not walking as fast. And then we started looking deeper into our data and found that more than half of our patients by MoCA score, which is another variable we collect now, were impaired. So half of the adult deformity population had impairment in their baseline cognitive performance. And just like with the grip strength, surgery actually improved their cognitive scores. So one of the lifts that you're getting maybe with their walking speed post-op is that you're actually improving them from a cognitive standpoint. It's hard to know which came first. It might be a cycle, but somehow improvement post-op also improved their cognitive scores. We're not making these patients worse cognitively, and it's probably linked into their activity. A few other things we've looked at, inflammatory state. Many patients become more inflamed as they age. This is linked in our data to major complication rate. Also, we're starting to look at automated radiomic assessments of sarcopenia. There are automated segmentation algorithms that now look at visceral fat versus muscle. And this has been linked to age and sex. So it seems to be accurately tracking with patients' decline with age. And also these algorithms can even automatically generate a fatty infiltration score. And we all know that patients with significant fatty infiltration, the degenerative back patient, the flat back patient, many times they don't improve quite as much when they have a lot of fatty infiltration of their muscle. They're also at greater risk of proximal junctional failure. So I think in the future, we're going to see a lot more of these automated body composition capabilities coming from radiology and radiomics into our predictive models. They've already started using some of these parameters based on automated sarcopenic assessment in clustering tumor patients. And it's been linked to tumor patient survival. So this is probably coming to the adult deformity and spine world pretty soon. The final part of the talk, I want to talk a bit more about our work in aging markers, which I think is one of the more interesting things and more interesting variables that we're going to add. We have not done a good job in figuring out when to operate on patients and on how prehabilitation can improve the phenotype of the patients we're operating on. And this is where I think it's really going to help us to figure out when to pull the trigger to maximize the patient's area under their health curve. So we started out working with telomeres. Why did we start there? Because Elizabeth Blackburn, the Nobel Prize winner who identified telomeres, is at my institution. And we first linked telomeres to risk of major complication. Patients that, I don't know why that box has moved like that. The patients that had complications that had the shortest quartile of telomeres were 26-fold more likely to have a major complication than patients with the longest telomeres. So telomere length, which is which regulates the ultimate number of cell divisions that are possible, is linked to major complication. And this actually won the Hibbs Award for the Scoliosis Research Society in 2021. But telomeres are a variable measure. They're very technique specific. And the aging literature, interestingly, has moved away from telomeres. And this was just a small pilot study we did And we were getting a lot of outside counsel from our aging experts to move more into epigenetics and away from telomeres. So we began a collaboration with a company called True Diagnostic. True Diagnostic does a lot of core processing of epigenetic aging markers. And we started to work in this clock called Dunedin Pace. Dunedin Pace was based on 1,000 New Zealanders that they followed for more than 50 years. And unlike the clocks like Horvath and Hannum, the first generation clocks, Dunedin Pace doesn't measure mortality. Dunedin Pace measures the instantaneous pace of aging. And they follow these patients over 50 years, and they continue to follow them. They bring them in every 5 years and do comorbidity assessments. And what we found was Dunedin Pace, the instantaneous pace of aging, was linked to the adult spinal deformity frailty index that we previously developed, which started to make us think this is related to frailty. And then also Dunedin Pace has been linked. We all know, if you, especially those of us who are getting older, we follow a lot of the caloric restriction literature. Dunedin Pace is responsive to caloric restriction. It's a prospective trial of caloric restriction, and they saw a decrease in or an improvement in Dunedin Pace with calorie restriction. When we looked at Dunedin Pace for major complication, we saw that the patients that had a major complication on average were aging 13 months per year, versus the patients who didn't have a complication were aging at about 12 months a year, or a normal rate of aging. So an accelerated pace of aging was linked to major complication rate, and this paper is currently in review. It's also measuring something different. Epigenetic age did not equal the disability scores that we typically use. There was not a relationship. And we think that this is going to be one part of the equation. So we may continue to use telomeres. We're going to add in epigenetic aging. We've looked at metabolism and metabolomics, or proteomics, for physiologic measures of, for example, the stress of surgery on a patient, to kind of measure their physiologic profile. But there's good data now to show that epi scores, which are essentially an epigenetic surrogate for metabolomics and proteomics, may be more stable over time, like an A1C is more stable than a spot check of glucose. And this may be a better way to go. So we're starting to look at epigenetic scores that may predict the metabolome rather than just looking at metabolomics. And there's been a lot of good publications in this that you guys can look up on the development of epi scores for various things like Alzheimer's disease, et cetera. We're also looking at individualized biomarkers, physiologic markers. You can see on the left the ones that were used in generating the Horvath and phenoaging scores. And again, there are now epigenetic biomarkers for these, and they've been linked to things like sarcopenia and grip strain. What do we want to do with this? We want to improve the clustering. So we think we're going to add all these different aging-related variables, add in walking speed, sarcopenia, maybe CT-based radiomic scores, and this will improve our ability to differentiate between patients. And then finally, where is our research going? Just like tumor work has now become essentially genetics, we are now doing tissue harvesting at our surgeries. We're building a large spinal tissue bank in the United States, and in collaboration with the European Spine Study Group. And at every surgery now, we're collecting all these tissues: saliva, whole blood, bone, bone marrow aspirate, muscle, adipose tissue, and then even fusion bone, scar tissue, urine stool for the microbiome. So this is a large effort which will consume a lot of our work over the next 5 to 10 years. And we started to talk to Sarah Voisin, who wrote this paper for epigenetic clock of human skeletal muscle, on how we might collaborate to generate an epigenetic clock for spinal muscle, for example, that may be predictive of mechanical complications. So this is where we're going. We do believe all this needs to be integrated into a loop improvement process, where we measure all the preoperative data. We measure our epi scores, our muscle scores, our objective walking speed data, and our radiomics data. and we measure our outcomes, and then we feed this back into an improvement loop, capturing all the data from a preoperative to postoperative time point. So thank you very much, and I think I'll stop there, and appreciate the invitation again.
Thank you, Chris. That's an impressive amount of work from different dimensions. Thank you for sharing it with us. While we wait for some of the questions to be pushed through, Marcel, what do you think?
Well, very impressive. I would say it's mind-blowing. One of the questions I have while waiting for other questions from the colleagues is about this use in kind of appropriate consent of the patient, because what we normally do, what normally our trainees do, when they consent the patient for surgery, they'll give some numbers of some meta-analysis or some randomized control study from a center which was done elsewhere, somewhere in New York, in Korea, by some surgeons, and they would not correlate to a specific surgeon in a specific unit, in a specific city, in a specific and kind of healthcare system. How far is this to be implemented as a routine? Do you think it will be implemented as a routine? Because a complication in somebody who never did the surgery in, I don't know, in the UK would be different than a risk of complication of somebody who is doing this surgery routinely somewhere elsewhere.
It's a good question, and I'll give you kind of the practical experience. The International Spine Study Group and the European group wanted to make this available. To make it available, we had to go through a process of getting FDA approval, for example, and getting European approval to do that, and it was quite expensive. So we were going to partner with an industry partner to do it, and then the registries felt that it was too proprietary. They didn't want to give it to one industry partner. So it's just the practical aspects of life. We're thinking of other avenues that we could potentially explore, like such as AO, Innovation Hub, incubators that may allow us to go through the approval process to do it. Because as you mentioned, it's not as easy as just releasing the current version of a calculator. We want to make it a living organism and something that improves with time. And we want to allow it to be trained to an individual surgeon's practice. And to build in all those capabilities requires expense. The easiest way to get the money is from an industry partner. But then, if you have 15 surgeons in a registry, 5 of them might work with Medtronic, 5 might work with NuVasive, and getting them all to agree on, the appropriate industry partner is difficult. So probably an impartial partner sponsor is going to be the better way to go. And in terms of the informed consent process, this is exactly right. We had quoted patients' average values. That's the best we could do, and that's even, going the extra mile, or reading the literature and giving them the most appropriate, most recent literature. But it's not really reflective. It's not very accurate for predicting a patient's individualized risk, and it's messy. And that's one of the reasons that the societies have kind of pulled back, and they're like, I don't know about this. I really just want to do basic scoring systems like Frailty or things like this. But unfortunately, that's not accurate. That's just not truth. So we have, as surgeons who know data, we have to say, no, we have to figure out a way to do this together. We can do it in conjunction with large societies like EANS or Eurospine, SRS, North American Spine Society. But the societies have to come together and say, no, the Frailty scores and R squared was 1990s or 2000s. And we're moving beyond that to become more accurate, and it has to be multivariate models.
Yeah, very interesting altogether. I mean, the machine learning is basically pattern recognition, right? And from that, with all sorts of other data input and processing, we can get predictive analytics. How accurate do you think the current models are, the ones you're dealing with? And how reliably can you tell a patient no when the computer says no?
Yeah, a good question. Our models, depending on the time point we looked at and the outcome instrument we looked at, were somewhere between 60 to 80% accurate for complication and outcome. they were more accurate the more data we added. So if you add surgeon, if you add site, if you get closer into surgery or even closer out of surgery, like once surgery is done, predicting the 2-year revision rate is better than before surgery. So all that makes sense. Also, objective variables were better predicted than mental variables, which were more difficult and it all makes sense, right? But we found that adding more and more patients, we weren't getting more accurate. So that's why we shifted a little bit in our direction. To me, though, as you mentioned, the most useful to me is the patient to say no to. And, just like you guys, we practice in a large tertiary center. Our patients come to us from far away. They travel, they spend money to come sit in our waiting rooms. And the local surgeon tells them that we're going to fix them. And then they come in and we say no. And we're now rated, right? Patients like rank us, they give us stars like you're buying something on Amazon or something, right?
Yeah.
And our most disgruntled patients were the ones we said no to, because they're like, you don't know what you're talking about. I traveled, all this distance. And so for us, if we have a calculator, we say, look, I don't think surgery is going to help you for various reasons, but I'm going to run this calculator and see what the calculator says. The calculator is completely impartial. And if the calculator also said your likelihood of reaching MCID was 5% and your likelihood of a major complication was more than 50% and reoperation was, 70%, then the patients seem to take it better. So it's like an instantaneous, impartial, multidisciplinary panel or second opinion that's completely unbiased. It's not completely accurate, but it's unbiased. And one more point on the accuracy that's kind of funny if you think about it. So if we as humans, we bet more than 50% accurate, what do we say about ourselves? We're like, we're doing pretty good. If a computer is 80% accurate, a lot of times the surgeons say, oh, that's terrible. It's 20% inaccurate, right? So we're much more tolerant of human inaccuracy than we are tolerant of AI inaccuracy. And even if the AI is 30% more accurate at predicting than humans, we hold it to a higher standard than we do humans. So the AI is probably never going to be 99% accurate because there's some element of chance. It's poker, not chess. And we're going to have to learn to accept that there's going to be some error. Just like when a Tesla has an accident, everybody says, oh my God, look how dangerous the Tesla is, right? But humans, of course, are running into each other every day on the highway and no one says anything. So some of it's a socialization of technology too, I think.
Absolutely. One of the questions coming through, in fact, it's more than once, so I'll combine them, is about learning curves. You mentioned learning curves and optimizing outcomes, which also depends on volume. And therefore, is this a type of surgery that should be centralized? And will the data out of a centralized tertiary service be more useful in the predictive analytics than from small bits of data from small centers? It's a subjective question, but what do you think about the quality of service that can be given by small units versus big units, and as related to the data that will generate?
Yeah, really good question. A couple points on it. You would think that in some ways it's going to be more in alignment or more favorable for large tertiary experience centers that are doing very high volume. But if you think about it another way, it may actually be protective of the experience of the good surgeon. We've all seen them, the young fellow who's exceedingly good, who goes out in a small practice where they're not doing a lot of deformity or complex surgery, and he brings the predictive model with him or her, and the older partners are like, oh, you're having a lot of reoperation, your complication rates are high, you're not doing a good job. That surgeon can run the predictive models from the ESSG, the top surgeons in deformity maybe in Europe, and say, actually, you know what, I'm doing the same as these guys. For my patient population, I'm doing the same as these guys, so you're wrong. and it might be in support of that lower volume but still very good surgeon. But yes, I mean, you don't know. It's definitely going to do a better job of predicting what your complication and quality benchmarks should be. That's for sure. It's also it's true though that one other aspect of it that's interesting that I learned along the way is that there are benchmark predictive models. For example, when you do inventory for convenience stores, they have companies that predict how many eggs they should buy. Initially, they use a predictive model that they just have for all the convenience stores across Europe, for example. But then over time, taking a smaller amount of data, they can train that model to be more specific to that one convenience store. There are methods of doing that. So that it applies to surgery as well. Initially, you would have a benchmark model, but then after you have 25 to 50 cases, you don't need to have another 5,000 cases to train it to you. You can just enter your small amount of data, and the benchmark model will start to become more accurate for you based on entering a small amount of data. And there are various ways to train it to allow it to become more accurate for an individualized practice. So you don't have to have the same number of patients, for example, as ESSG entered for it to be accurate for you.
Thank you. That's very good thinking. Marcel, do you have any questions on your side?
Nothing else. I just admire. It's fantastic talk on very exciting topic. It has been recorded, and a lot of people probably will watch it later on. I would like to rewatch it again. I've learned a lot, but something I'll fine tune later probably. Fantastic. Thank you very much, Christopher.
Chris, one last question then. We have young neurosurgeons who are probably still at work, and indeed they will catch this on the YouTube later, because this is kind of plugged towards the end of the day, but not quite at the end of the day. What advice would you give to someone who's a neurosurgeon? We're in the ENS, who wants to be a spinal neurosurgeon and who wants to do adult deformity? Any tips?
Yeah, I think first of all, I'd say it's been a really exciting disease model. So if you just look at it from a research standpoint, it represents a very exciting model to work in for research, because there's still a lot of optimization to do. When you think of minimally invasive surgery, some of the top minimally invasive and endoscopic surgeons, they're super good, and I think the care of those patients has been optimized quite a bit, but we still have a long way to go in making the care of the aging population for these deformities as safe as possible, and even trying to figure out why patients develop these deformities as they age and why some don't. So from a care optimization standpoint and a research standpoint, it's really a very exciting field to go into. And I found it to be a really good community of surgeons who look out for each other and great mentors. And so I think the most important thing is to find a surgeon in Europe or US or Canada that you admire their research work, their clinical work, and find a good mentor. It's very helpful and critical really in complex surgery, just like vascular surgery or any type of skull-based surgery, or the most en bloc resection surgery or something like this. You have to find a good mentor you admire clinically in research and foster that relationship.
Great. Well, I think that's a fantastic place to wrap it up. Again, on behalf of everyone, thank you, Chris, for your time, your precious time. We've covered a lot of stuff, from frailty to sarcopenia to aging markers and epigenetics to cost effectiveness, quality of data, machine learning. There's so much more. This is definitely worth coming back to. We look forward to seeing you again in our events, and thank you yet again for a fantastic contribution.
Thank you both very much. Great to spend time with you. Hope to see you soon.
See you soon. Take care.
Bye.
Okay, thank you, Marcel. I think we can close it. Thank you.